Hello, can I be heard?
Yes, Jonathan, you can be heard. Good evening. Thank you. Amen.
Amen. Thank you too. Yeah, so we are all welcome once again. Before we start dive into the presentation, we will take a welcome address from the chairman of the association or the branch, Dr. Richard Bright Daniel. Dr. Daniel, your audience are on their ears.
Yes, yes. And also on their phones or laptops. Thank you very much.
Yes.
And good evening. Good evening, ladies and gentlemen. A warm welcome to you all. I'm happy to meet all of us. I can see some familiar names, some familiar people, some names I'm probably going to see for the first time from diverse professional groups and affiliations. But we all know that our common interest is the Ghanaian child. As we may know, pneumonia in children is important. And the importance is not just because of the deaths associated with the disease, but importantly is the increasing direct and indirect costs of the disease entity called pneumonia. And we are talking about hospital resources allocation, loss of school and then work hours, amongst others. Over the next few hours, we are happy to engage you. We are going to delve into getting things right in relation to pediatric pneumonias. We want to say a huge thank you to our speaker, our facilitator, who happens to be my teacher as well. We are grateful to the organizing team for putting this together. And we are also happy to have you who have joined us in this CPD. As we refresh our memories, sharpen our skills together, share best practices, we hope that we build on some collaborative efforts in managing children who have pediatric pneumonia in our region and beyond. May I render the best care for children with pneumonia, yield the necessary dividends as we engage in this CPD. Once again, I want to welcome all of you, and then we pray for a very fruitful engagement and discussions. Akpena Mikakaka, Jonathan, over.
Thank you, boss. So today we are coming to talk about pneumonia in children, getting things right. And we have a seasoned personality that is going to take us through this topic, and it's a pediatrician and then a pulmonologist at Kolebu Teaching Hospital, Accra. She's committed to advancing child lung health through clinical care, research, and advocacy. She also established a hospital pediatric pulmonology clinic and introduced spirometry service, expanding access to specialized care for children. Her research focuses on lungs functioning in children with tuberculosis and chronic pulmonary disease, with several previewed publications to her credit. Beyond the clinic, she actively championed Clean Air Initiative, leading national awareness campaign on asthma, air pollution, and lung health. She also served as a general secretary of the pulmonology group of the Pediatric Society of Ghana and head of telemedicine committee at Kolebu Teaching Hospital. She enjoys reading and writing fictions as her hobby. Ladies and gentlemen, let's welcome Dr. Yaira Wadri. Hi, Doc. You are welcome. Hello, Dr. Sairam. Hello, Dr. Saram. You're welcome. I hope you can hear me. I'm sure she's getting herself ready. So,
Sorry, I was muted and I hadn't realized. I hope you can hear me now.
yes, please, we can hear you now. You are
Okay,
welcome.
sorry. Thank you so much. Um, yes, thank you. And can you see my screen, please?
Very well.
The presentation.
Yes, please.
Okay, great. Thank you very much for this opportunity. I started work in the Volta region and I spent all my childhood and early adulthood life in the Volta region. So I'm an honorary member of the Volta division. So
That's okay. Thank you.
Wright has asked me to talk about pneumonia, getting things right. I'm hoping that the getting things right part will come as we go along. We can see where more work is needed and where we are doing very well. So we will start by looking at the things that I'm hoping we will be able to take from this presentation. So the commonest cause of pneumonia that we are likely to come across is what is called community-acquired pneumonia. So the focus will be on community-acquired pneumonia. I'm hoping that each of us will be able to define community-acquired pneumonia. There are things that cause pneumonia, and of the pneumonia that is caused by infections, I'm hoping that each of us will be able to list the commonest causative group of organisms. So not the individual names, but what group of organisms cause community-acquired pneumonia. For all children, we'll list 5 signs of pneumonia, 5 investigations that we can do for pneumonia, and mention the recommended first-line antibiotic or empiric antibiotic for treatment of community-acquired pneumonia. So I'm going to present a short case and we'll look at a brief introduction, epidemiology, which people get pneumonia, what causes pneumonia, how does it move from causative agent to disease, and how do our children present to us. Then differential diagnosis, when you see a child with pneumonia, are there other things to think about? What are they? How do we manage pneumonia? There are some emerging threats. What is new? And then we will conclude. So I'm presenting to you a 9-year-old HIV negative, fully immunized, well-nourished girl who comes to you with a 3-day history of fever, cough, and right-sided abdominal pain. Her temperature on presentation is 38.6 degrees Celsius. Her heart rate is 120 beats per minute. Her respiratory rate is 20 breaths per minute. Oxygen saturation is 97% in room air. She appears mildly ill with crepitations over the right lung base on auscultation. So, you diagnose her with right lower lobe community acquired pneumonia. I would like to take from the audience what should be the appropriate next step. Since I can't look in the comments, moderator, if there are any answers in the comments, you mention it for me. Or if somebody feels like talking, you can just unmute and talk.
Okay. Hello, any answer, please? Anyone with an option?
Maybe we will do it
Look, there are
like
some comments in the comment section. People are choosing B. That's order a chest X-ray to confirm pneumonia. 3 people with
okay,
B. 1 person
okay,
with C.
okay.
Yeah, a chest X-ray and full blood count for focus.
Okay. All right. Great. So the next step, a 5-day course of oral amoxicillin is prescribed, and that is the correct next step. 2 days later, she's seen in the emergency room with worsening tachypnea, fever, chest pain, abdominal pain, and vomiting. What is the appropriate next investigation?
Please, you can type your answer in the comment section. There is a different scenario.
So it's the same child. You initially prescribed oral amoxicillin, which is the correct thing to do. But 2 days later, she has worsened and come. So what is the appropriate next investigation?
Yeah, so there are some answers in the comment section too.
Okay,
It goes for A, order a chest X-ray.
great.
Somebody
So
also
you
said
will now, yes, sorry.
somebody also chose B.
Okay, but you will now order a chest x-ray.
Okay.
So you order a chest x-ray and it reveals a right lower lobe pneumonia with a large pleural effusion. You then go ahead to admit her to the hospital for management of complicated community-acquired pneumonia with IV ampicillin. Fortunately, you are able to do PCR test, which is a faster test. It's a molecular-based test, so it's like the way we do an HIV test. You put it on a cassette, sort of. So you're able to do a PCR test and of the pleural fluid that you have drained. So you pass a chest tube and then you take the fluid for testing, and it shows Streptococcus pneumonia. You continue to give her IV ampicillin. By day 5, she's discharged home to complete a course of oral amoxicillin. So this is a typical presentation of pneumonia. This is how children present to us with pneumonia. Now, why is pneumonia important? There are many things that are plaguing children. Why are we focused on pneumonia? As the advert said, it's because pneumonia is the commonest cause of morbidity among children, the commonest cause of death among children. And one thing about pneumonia that we don't think about, there are adults with chronic lung disease. They have symptoms, some of them are dependent on oxygen, that is, if they don't die. And usually, the origin of adult chronic lung disease is in childhood. And so, looking beyond the numbers of death and the numbers of hospital admission, if we do the right things for our children with pneumonia, we are preventing chronic lung disease in adults' life. Globally, all over the world, in 2012, the causes of child death are as I have projected on the screen. They don't add up to 100% because I just choose some to highlight the commonest. So pneumonia, including pneumonia in the neonatal period, is the commonest cause of death. Then we have preterm birth complications, intrapartum problems, diarrhea, and malaria. So these are the things killing our children all over the world. Now, when you come closer home, this data is from Navrongo. In Ghana, we have malaria on top, then we have acute respiratory tract infection, and then we have neonatal pneumonia. But when you add acute respiratory tract infection and neonatal pneumonia, it overtakes malaria. So even locally, chest infections, pneumonia are killing our children. It helps to be able to define pneumonia, what we are talking about. There are many definitions of pneumonia, and it depends on where you are working. That's the interesting thing about how to define pneumonia. Pneumonia in certain settings is defined as an acute infection of the lower respiratory tract. Okay. The problem with this definition is that, as we may know, there are many things in the lower respiratory tract. It's not only the lungs that are in the lower respiratory tract. Okay, so we also have the airways, the lower airways. We have the pleura. So there are many things in the lower respiratory tract. Pneumonia is more specifically, because now you are narrowing down. It's a lung infection, so an inflammation of the lung parenchyma. So excuse me for calling it an infection, because actually many things cause pneumonia. It's not necessarily an infection. So pneumonia is inflammation of the lung parenchyma, the lung tissue itself. Okay, to contrast, you can have inflammation of the airways, and that is asthma. But pneumonia is for the lung tissue itself. That excludes the airways. That's also a definition in another setting. In another setting, pneumonia is defined as fever, acute respiratory symptoms, or both, with parenchymal infiltration on chest X-ray. The problem with this definition is that in most of our settings, we don't have chest X-ray. And so if you needed chest X-ray to diagnose pneumonia, then you will never diagnose pneumonia. WHO has a definition that works very well in low middle income countries. WHO defines pneumonia as cough, difficulty breathing, tachypnea, and chest indrawing. As you may know, WHO, for anything that has to do with public health programs, they are not exactly interested in being precise. They want impact. So this definition allows you to capture every child with pneumonia, but you are definitely going to capture children who don't also have pneumonia. But this definition is aiming at preventing serious sickness and death, so not scientific accuracy, because people can have cough, difficulty breathing, tachypnea, chest indrawing from heart failure, for instance. They can have this from nephrotic syndrome with pleural effusion, but the aim here is to prevent children dying. So with these four definitions above, we narrow to community-acquired pneumonia, which I've abbreviated to CAP on the screen. It's pneumonia in a person outside the hospital setting. So that person has pneumonia, but was not on admission when they had the pneumonia. They are coming to you from the community with pneumonia. That is community-acquired pneumonia. And that is where our focus is, because that's where the majority of children with pneumonia come from. Who can get pneumonia? Who is at risk? Infants are at risk. I mean, any child from birth to less than a year is at risk of pneumonia. And the reason is that they are still developing their immune system. The things you and I have seen and handled, maybe it's really brought us down, but we have recovered. And for that reason, we have memory. When our body encounters it, because we have memory, we are able to fight it quickly and overcome. Infants don't have that. They are now getting exposed to all these things. And so the things that cause pneumonia can really make them very sick. Suboptimal breastfeeding. As a person working with children, you can never talk too much about breastfeeding. Breastfeeding is food, and it is water, and it is medication. Breastfeeding protects against pneumonia. Currently, less than half of all women in Ghana are doing exclusive breastfeeding. When we don't breastfeed, it puts our children at risk of pneumonia. Why? Because there are a lot of immunoglobulins. So to put it plainly, they are like medications against viruses. And as we go on, you will see the role of viruses in pneumonia. So if you don't breastfeed optimally, your child is at a higher risk of pneumonia than other children who are optimally breastfed. Immunization. Of all the things that have been game changers in child health, immunization is one, the next is breastfeeding. These two things are the things that have made a difference in survival of children all over the world. Now, our immunization contains vaccines against pneumococcal pneumonia. And in low middle income countries, two bacteria are responsible for most of the pneumonia: Streptococcus pneumonia and Staphylococcus aureus. And now our immunization since 2012 contains the PCV against pneumococcus. So if children are not immunized, they are at risk of pneumonia. Even before that, Haemophilus was part of our immunization. Malnutrition, children who are not well nourished, and the origin is from pregnancy. Some are born preterm, so they were small already, and then they were not breastfed, or some were born at term, but they were not breastfed, so they already had some malnutrition, and so on and so forth. And then we all are poor, and so when you are poor, you either don't have the food, or because you didn't really go to school, you don't know the nutrition to give your child. We have some underlying illnesses, chronic illnesses like congenital heart disease, what we loosely call hole in heart, nephrotic syndrome, which gives some children some sort of lack of immunity, immunodeficiency. So when we talk about immunodeficiency, most of the time we think only about HIV. So when the HIV test is negative, we test again because maybe we are wrong, the test kit is not okay, then we test a third time. But there are other causes of immunodeficiency. Some children are born with immunodeficiency, which is not HIV. We call that primary immunodeficiency or inborn errors of immunity. So some children have immunodeficiency that they are born with. So if you test for HIV and it's negative, think about primary immunodeficiency. But primary immunodeficiency and HIV and immunodeficiency from, say, a child who is receiving strong medicines for cancer and so on, they are all at increased risk of pneumonia. Low maternal education, this one has been steadily documented that as women get more educated, the health of their children improve. Low socioeconomic status. When you are poor, you are at more risk of certain diseases, and pneumonia is one. All diseases that are airborne, because of overcrowding, then you increase your risk. And smoke exposure or indoor air pollution. This smoke could be tobacco smoke. It could be smoke from cooking indoors with wood fuels, indoor air pollution. Some of us live in homes where we hardly open the windows, and we don't also, I mean, the windows are closed, and it's not like they are closed because we are using air conditioners. Our rooms are very stuffy, there are sprays all the time, the air quality is very bad. That will predispose towards pneumonia. So what are the things that cause pneumonia? The big group is infections, so infectious causes of pneumonia. It could be viruses, it could be bacteria, it could be fungi, it could be parasites. But we also have non-infectious causes of pneumonia, and we need to start thinking about them. A child is eating and the food goes into the lung, or a child has reflux and it ends up in the lung. Aspiration can cause pneumonia. Hypersensitivity reactions. A child lives in a place that is very moldy, and then they react to the mold, or you give some medication and they react to it. So drug induced radiation induced. There are autoimmune conditions that are rare, but they are there. SLE and so on and so forth. They can cause pneumonia. Rheumatoid arthritis, they all can cause pneumonia. But what I think we fail to think about, which is quite common, is aspiration. Usually when aspiration is very big, the child has had a big breastfeed and it ends up in the lung. Because it presents very catastrophically, all of a sudden they finish eating, they can't breathe. We think about it, but what we don't think about is the micro aspiration. This child keeps coming with pneumonia. They haven't reported any aspiration episodes, but of the things you are thinking about, still think about aspiration in tiny amounts, not the big one that after they have just fed, then they become breathless. So I want us now to look at the infectious causes of pneumonia. So pneumonia from infections, okay? The reason I'm bringing this slide is that we all need to understand the infections that cause pneumonia, because when it comes to treating it, it guides us to choose the medications. So newborns who are less than 3 weeks old, bacteria organisms are on top. So we have group B strep, E. coli, gram-negative bacilli, strep pneumoniae, Haemophilus influenzae, which we vaccinate against. From 3 weeks to 3 months, the commonest causes of pneumonia are viruses. Respiratory syncytial virus, RSV, is the commonest cause. And then we have other respiratory viruses like rhinoviruses, which causes common cold, parainfluenza, influenza, and so on. Before we come to the bacteria, strep pneumonia, H. flu, and so on. 4 months to 4 years is still RSV at the top and other viruses at the top. Okay. And then we have the bacteria, and then we come to the atypical ones. More than 5 years, commonest is Mycoplasma pneumoniae, which is an atypical bacteria, and then we have strep, chlamydia, H. influenza, and before we come to the viruses, but the viruses are still here. They are a very big cause. So when you put all children together, no matter the age, what is the commonest cause of pneumonia? It is viruses. It's viruses, no matter the age. When you put all children together, the commonest cause of pneumonia is viruses. It is not bacteria. Why is this important? When it comes to treatment, you need to remember what is the commonest cause of pneumonia among children. So, yeah, a child is there and breathes in some virus. How come some people develop pneumonia and some don't develop pneumonia? So let's look at the pathogenesis. We cannot talk about pathogenesis without talking about the things that protect children from pneumonia. So those are the host defense factors. So we start from our nose. In the nose, when you look in the nose, it's not just a hole. We have hairs in our nose. And then we have these turbinates that are like sort of like protrusions, soft protrusions in our nostrils. And from the nose all the way down, it's not straight, it branches. Two nares or nostrils, they come together, they walk down straight, they branch again, and then they keep branching, and then they come to the bronchi, they divide into two. So it's not straight. God made it that way. We have hairs, and the hairs, dirt and germs get trapped in the hairs of our nose. And what do? We sneeze them. And then the turbinates also trap them. And because the tracheobronchial tree is branched, it's not straight, it's difficult for things to pass because you have to meander your way and you need to have a certain size before you are able to go down. Then our respiratory tract is lined with, we have the hair still going down beyond the nose, we have the hair, but we have mucus sitting on top of the hair. So the mucus traps these things that are not supposed to go into our airway. Dust, dirt, germs, the mucus traps it. And then the cilia, they beat like a broom. It sweeps it up. Sometimes we cough it out. Sometimes we just, we swallow it. Then in our respiratory tract, we have some things that can kill bacteria in the mucociliary lining, in the mucous lining of our respiratory tract. For example, we have secretory immunoglobulin A. So I was saying that some children are born with primary immunodeficiency. Some children are born, they can't produce immunoglobulin A. Immunoglobulin A is part of our defense mechanisms. And then our ability to gag or choke protects things from getting into our airway. That is why when somebody is comatose and they've lost the gag reflex, we always talk about protecting the airway. We don't feed them, we don't put food in their mouth to swallow. And we want to put them on the side so that secretions can drain down. Because if the secretion is going the wrong way, they cannot gag or they can't choke. You know, the action that we do is a gag, but to explain it plainly, it's as if you are choking on it. And then the cough reflex, the ability to cough. The ability to cough is one of the biggest blessings when it comes to the chest. But what do? We are always trying to suppress this ability to cough. It is our cough that prevents things from going down our airway. Let's say you are drinking water and it goes the wrong way. What do? Or food. You are eating and you are talking and it goes the wrong way. You cough until it comes out. The cough reflex is very, very important. There are children who cannot cough. Say children with neuromuscular diseases, like we talk about things like Duchenne muscular dystrophy, children with poliomyelitis, those ones, they can't cough. Or children who are unconscious, they can't cough. They get pneumonia. The cough reflex protects us. I do a lot of social media, and the way I have explained this in one of my videos is that the cough is like God giving us a broom to sweep our airways. So just imagine, it's, you know, all these things, mucociliary clearance and so on, when it moves the thing up, you cough it out. So the cough reflex is very, very, very important. Cough is not an enemy. Cough is not supposed to be suppressed. There are some situations where in specialist care, you want to suppress certain coughs, but that is rare. You want airway to be cleared because the moment you leave pus and plenty mucus and gunk in the airway, what do? You've created a boarding house for germs. They thrive in that pool you have created. So cough, part of our host defense mechanisms. Please let's stop suppressing it. And then we all have what we call normal flora. I think it's very popular when we think about the skin. Our skin has normal flora. We don't want our skin to be clean as if we are going to have surgery and the surgeon is scrubbing. The same idea applies to the respiratory tract. We have normal flora. There are organisms that are sitting there. They are happy. They are in harmony with us. They don't cause any problem. Those are the normal flora. But when you keep giving antibiotics, you clean all the normal flora, you kill them. And what happens? Organisms that should not thrive now thrive and cause problems. Normal flora, very important. So giving antibiotics at every cough is also very bad. And beyond the fact that you know when you destroy the normal flora, you put the child at risk of pneumonia. It's one of the reasons why people also get asthma. So we call it dysbiosis. You know, there's some harmony. Imagine a forest that Galamsey hasn't gone. Animals are there. The lion is their king, but they have an order. But when Galamsey goes in and destroys everything, then chaos. So the same thing in our respiratory tract. Then we have some cells called alveolar macrophages. They are in our blood, but then they can go into the tissue. They change into macrophages, and their job is to engulf or swallow germs. Also, so these are the most important things in our respiratory tract that protect us, and these things should be preserved. The hairs and turbinates, for instance, if you begin to now smoke and vape as teenagers are doing now, you destroy all the hairs in your mucociliary tract. You even destroy the mucous lining, and that also puts you at risk of pneumonia. Because viruses are the commonest causes of pneumonia, how does it evolve from a virus to pneumonia? So people who are going to get pneumonia from viruses, usually they have like a cough and cold first. And then for some reason, the infection that happened in the nose and upper airway spreads down along the airways. It goes down. As this infection is going down, the respiratory epithelium is injured directly. And once the respiratory epithelium is injured, or the lining of the respiratory tract is injured, certain things called cytokines, you can think about them as hormones, are released into our bloodstream. And these cytokines are responsible for most of the systemic symptoms, like the headache, the not feeling so well, myalgia, the temperature, the vomiting. The cytokines cause that problem. Because there is direct injury to the respiratory epithelium, there is now swelling of the respiratory epithelium, and the epithelium is lining the respiratory tract. So once there's swelling, the airway now narrows a bit. And when macrophages also come in and they move to the site and engulf all the things, the germs, all the injury that is happening, the dead cells, they come and engulf it. They also contribute to the airway obstruction. And because of the injury to the respiratory epithelium, we produce a lot more mucus, and all that contribute to the airway obstruction, so our airways can get blocked. Because now there's a lot of mucus that we are producing, the mucus blocks the small airways and it causes what is called atelectasis or collapse of the airways. There's some edema in the interstitium of the lungs. And then the lungs are made in such a way that wherever air is going, blood must flow. But when there is blockage, there is now blood flowing in parts of the lung where there is no air going because of that blockage. Then there's what we call ventilation perfusion mismatch. And the end product of that thing, that physiology, is that oxygen saturations go down. Now, it started as a viral pneumonia, but oftentimes there will now be superimposed bacterial infection because the normal order of things have been destroyed. Then there can be superimposed bacterial infection from that process. Similar thing happens in bacterial pneumonia. The bacteria either go into the airway directly or they spread through blood. What is we call hematogenous spread. But in bacterial pneumonia, some bacteria have characteristic ways that the thing presents. If you were looking at it in, say, a pathology specimen, you were looking at it under the microscope, or you were looking at an X-ray. So Mycoplasma, it spreads the infection along the bronchial tree, so it looks more like a bronchopneumonia. Strep pneumonia is focal involvement, so that is what causes our typical like lobar pneumonia. It's not diffuse, it's dense. Staph aureus causes what is called necrotizing pneumonia. What happens is that it's just sort of, in fact, parts of the lung. So it's all one huge mess of dying tissue, dead tissue. In between somewhere, there's an island of viable tissue that is functioning well, and then it can leave holes in the lung, which you call cavitations or pneumatocysts, and it causes empyema, thick pus in the lungs. Pneumocystis jirovecii and cytomegalovirus, they tend to cause lung cysts. All of these patterns you can see on X-ray or on pathology specimens. So this is just some pathology that I don't know whether it's relevant, I'm not sure. So we have stage of congestion, red hepatization. I will not spend any time on that, and we just move on. And again, this is pathology specimen. So how does it present now after all these things? What happens? I talked about most of them already. It looks like an upper respiratory tract. So the child may have cough and cold, and then constitutional symptoms, headache, myalgia, shivering, fever. They don't want to eat. They are vomiting. Of course, they will cough. They will cough because they need to cough. You see, all that thing in the airway that is causing the obstruction, it needs to be coughed out. They have chest pain. Some children will have abdominal pain from lower lobe pneumonia because of the relationship of the chest, the diaphragm, and the abdomen. They may have abdominal pain. The part of the body where the pneumonia is, let's say the pneumonia is on the right, because it is painful to move the chest on the right, the children do what we call splinting. They hold the arm very close to that right side. They don't want to move it. That's splinting. So sometimes when they are well enough to walk, as they walk, you see that they don't want to move that side. And then some children will have abdominal distension, possibly because of cytokine effects, possibly because they've been vomiting, and then they may have electrolyte imbalances, hypokalemia, and it's as if they've developed an intestinal obstruction. They may have abdominal distension. And we know that clinically, well, after you take your history, you've got your symptoms. We now have to examine the child, and we start from inspection, palpation, percussion, auscultation. So on inspection, you may see the splinting that I've talked about, tachypnea. They breathe very fast, and tachypnea is defined according to age, and there are cutoffs for the various ages. And then increased work of breathing. You can see they are struggling to breathe. They are cyanosed. They are not active, they are lethargic. And if you go through the examination, what we call tactile fremetus, you touch the chest as they are making a sound, you see that it feels different. It increased. The feeling you get is increased. So that's a tactile fremetus. And then you percuss. Today on the ward, I percussed a baby, a neonate. Because, I mean, we needed to decide, whether it was a mass or whether. I said, let's percuss. It will tell us. And percuss, it was down. So dullness to percussion, although this may happen in the later stages, because that's when you've seen the consolidation. The consolidation is from the dullness, so it may not be at the onset. Or if there's a fusion, sometimes it's stony dull, if the fusion is large enough. You auscultate, increase vocal resonance. As they make a sound, you hear it in your stethoscope. It sounds deeper or louder. There's reduced air entry on the affected side. There are bronchial breath sounds. There's crepitations. There may be rhonchi. And when you go down, there may be hepatomegaly. Hepatomegaly happens because sometimes there's a lot of air trapping in the chest. There's so much air that's not coming out because of the blockage, and it pushes the liver down. So that's like an artificial hepatomegaly. But sometimes children who get pneumonia, especially the ones from the viruses, they easily get heart failure. It could be from myocarditis, could be from severe anemia. And then because of the heart failure, they have hepatomegaly. So what investigations should you do? You do not need to do any investigation to diagnose. And doing a chest X-ray, whether they had the pneumonia or not, is not, no guideline recommends it. It's not guideline recommended. That's one thing. It's a waste of resources. It's unnecessary exposure to radiation for the child. If they need it, fine, go ahead. But every cough and cold does not need a chest X-ray. Your clinical examination is the most important. Chest X-ray comes in if you are thinking there are complications. So like the initial child, 9-year-old girl who comes, you diagnose pneumonia, you are free to treat. You are free to treat because the child has typical symptoms, dullness to percussion, your auscultate, air entry is reduced, maybe you have palpitations, you are free to treat. You don't need an X-ray for that, and it is not recommended in any guideline. Okay, but where you need the X-ray, as I've said, is if you are afraid of, if you think that there are complications. So that girl went home on appropriate antibiotic, but came back and was worse. And when the X-ray was done, it showed a pleural effusion. So if you think maybe this is a pleural effusion, maybe this is a pneumothorax, maybe this is an empyema, or you are doubting your diagnosis, you think perhaps this is not pneumonia. Is this a foreign body sitting in the airway? Then a chest X-ray is warranted. These days, we talk about point of care ultrasound very fast. You carry it in the palm of your hand. If you know how to do it, you do your ultrasound, no radiation to the child, you make your diagnosis. Like I said, you don't need investigation all the time. The same applies to a full blood count. You do not need a full blood count to diagnose a pneumonia. It's unnecessary stress to the child. It's unnecessary stress to the health system. You can have a pneumonia and there will be nothing showing in your full blood counts. Okay? Because pneumonia, we are talking about the lung. And so even though oftentimes, there's hematogenous spread and all that, but you can have a focal infection in the lung. Sometimes nothing will show in your full blood counts. So again, if you are thinking, is this child also anemic, or this child is very, very sick, let me see what's happening with the blood count, or child is not recovering. Yeah. A C-reactive protein in certain places is very important to decide whether your child is getting better quickly. So you can do these infection markers, a procalcitonin, it goes up faster than a C-reactive protein. So you can do them both to track that the child is getting well. So there are some children who, when they fall sick, they can really, really fall sick because either they have immunodeficiency or they have underlying diseases, and you want to be sure that you just want to keep a very tight hand on them, see where things are going. You can do these infection markers. Their value is in doing it repeatedly. So you see, like if you have a CRP of 200, you want to be sure that the next time you do it's come down to 100 or 80 or 150. So the value is in doing it repeatedly. But if you are going to do only one, then it may not really be beneficial. Or sometimes you are not sure. Is the child sick? Is it just a cold? But I think in that situation, you should rely on your clinical history and ask them to come back sooner rather than later. Then let me see you in 2 days. But if the child worsens, they can come back. Because their real value is in following them to know where things are going. So for instance, if you do a CRP now for a child and it is 200, probably yesterday it was actually 300. So it doesn't give you much information. But if you are going to do it the next day, then it's fine because it's going to tell you whether the child is worsening or getting better. But a single CRP or PCT, procalcitonin, doesn't help. Erythrocyte sedimentation rate is also an infection marker. We most usually use it in TB. You want to see whether this problem is a long-standing problem or an acute problem. That is the value of the erythrocyte sedimentation rate. If this child has a high-grade fever and you want to know what organism is responsible, you can culture the blood. And it gives you antibiotic sensitivities as well. But the more appropriate specimen in pneumonia is actually sputum. Sputum is more appropriate. In children, they normally do not cough and bring out their sputum. But I think those who have had the chance of working in Kolebu know that we can induce the sputum for everybody, even for a newborn, we can induce the sputum. So if you really want to know what is there, you can do an induced sputum and send it to the lab. It's a more appropriate specimen than culture. And there are certain places where people are privileged. You can do a swab of the throat or the nasopharynx or whatever for respiratory viruses. It's very, very useful because, as I said, these things are usually caused by viruses, and you want to see that it's a virus and possibly which virus is causing this problem. So that's respiratory virus. In Accra, if you request it, if you are really interested in doing it, Lancet does it. If it's for a study, Noguchi does it, and so on. Serologic assays. Again, there are people who are privileged. They work in places where resources are much more available. So if you are thinking about things like cytomegalovirus, you can do serology for it. If you are thinking about PJP or PCP, as we used to call it, you can do serology for it. TB test, very, very important. One thing about pneumonia, about tuberculosis in infants, is that it presents just like a pneumonia. This picture we have of somebody who's been coughing for many years and is losing weight and has nice sweat is for older children, not infants. TB in infants presents as a pneumonia. And so when you see an infant who has pneumonia severe enough to be admitted, you should test for tuberculosis. I don't know how widely available it is, but now in a lot of centers there is stool gene expert. You can do gene expert on the stool, because when the children, the infants, they cough, they swallow it, and then it ends up in the stool. So that's for the same reason why we do a gastric lavage. But like I said, you can also do an induced sputum, and induced sputum is 3 times better than gastric lavage. And I mean, there are many studies to support this. So we really should be doing induced sputum. So if you get a chance to work where it's being done, you learn how to do it, and it makes a difference. Not just for pneumonia, but sometimes you want to see what is happening in the airway. Is the child bleeding and so on? Induced sputum is very helpful. And then we do some supportive investigations, because we are managing a whole person, not just the lung. If this baby hasn't been eating, has been vomiting, you want to know where your electrolytes are. You are managing pneumonia, all right, but this baby can have an acute kidney injury. If the children are very, very sick, an arterial blood gas helps you to make certain decisions about how to manage them, provided you are in a place where there are resources. So I've put a lot of investigations here, and on the next slide there are also some investigations, but the point I want to make is that you don't need to do a single investigation to diagnose pneumonia. It's not necessary. It all depends on the clinical question you have. If I have a question, is this child getting worse, then I want to do an x-ray. But if I don't have that question, I don't need an x-ray. If I have a question, this sounds like a pneumothorax, then I need an x-ray. But if I don't have that question, I don't. Should I transfuse? Should I not transfuse? The child looks pale, I'm not convinced. Then I need a full blood count. But otherwise, I don't need a full blood count. So that's one thing I want to say. If you are doing any test at all, especially if it's an infant, it's TB you should be testing for, because we don't want to miss TB. They are telling us that we are not diagnosing as much tuberculosis as it is, because adult TB is being diagnosed much more. And we know that children are even more susceptible than adults. So that's something to think about. So this is a chest x-ray. I'm seeing it nicely on my screen. I'm hoping you're also seeing it very nicely. And this is a typical picture of a viral pneumonia. It could be worse than this. Viral pneumonias could be worse than this. So what you see are diffuse, patchy, whitish streaks throughout the lung field, patchy infiltrates throughout. This is a picture of a viral pneumonia. This is your classic lobar pneumonia. So this is a thing that will be made by streptococcus, dense consolidation. And if you are interested in detail, the reason you know this is a consolidation and not a mass, for instance, is that you can see the airways through it. So that's what is called an air bronchogram, because a mass will also look opaque like this. Bleeding into the lung will look like this. And you see the picture that I showed of a viral pneumonia. There are also some parents who give oil to their children. They put it in their children's nose. Or maybe they are forcing it down the child's throat and it ends up the wrong way they aspirate. Oil can also look like that. And oil in the lungs, it can be devastating. Okay, so this is from a WHO handbook. It's a classification and treatment for pneumonia at lower level health facilities. So this is like our CHIPS compound in our clinics, depending on the level of the clinic. Some clinics are really big. So it says that if a child 2 to 59 months comes with cough and difficulty in breathing, cough and or difficulty in breathing, so they don't need the difficulty in breathing. There are three categories to put the child in. The first is the green, and we know when you see green, it means go, everything is fine. So it could just be a cough and cold, no pneumonia. Sometimes difficulty in breathing is just caused by a blocked nose. Okay. And then what you need to do is to advise the mom to use some means of unblocking it. They can put warm or towel in warm water, bring it to the child's nostrils to inhale. But the more I don't know appropriate thing or the more useful thing to do is saline nasal drops. They drop it in the nose as often as the nose is blocked. Sometimes we prescribe the saline drops and we don't tell them how often. So some people go and use it once a day. Some people go and use it thrice a day, 3 times a day. It won't make a difference. So as often as the nose is blocked, they drop in saline. And the saline makes the nasal discharge thin, not thick. And then the moms can help them to remove it. Our grandmothers or even mothers, they use their own mouth to suction it. It's very good suction. But obviously the problem is that it's not very hygienic. But I've also seen people using the bulb syringe. And you wonder how many organisms are sitting inside that bulb syringe. For our moms, we know we wash it or we chew stick or we use toothbrush and toothpaste. But the most important thing is that whatever they will do, let them unblock the nose. Mucus shouldn't sit in the nose and the child can breathe. So you see this child, it could be cough and cold, there's no pneumonia. Tell them to go home. Madam, if you see that your child's difficulty in breathing is getting worse, or if you see that your child is not eating or is very sick or temperature is very high or this or that, please come back to me. Then the yellow, they have fast breathing and they have chest indrawing, and you think it's this could be a pneumonia. You give oral amoxicillin, and again give them home care advice, because the oral amoxicillin, the child must swallow it. So if the child goes and is unable to take it, either refusing to take it or is vomiting it or not eating anything, it's probably going to be dehydrated and have electrolyte problems and begin to convulse and so on. So you tell them that they should come back. Or you see the child with danger signs. So danger signs are a child who's convulsing, a child who is very lethargic, a child who is blue or cyanosed, severe pneumonia or very severe pneumonia or very severe disease. It may not be pneumonia. You give the first dose of antibiotic and then you refer to a facility for injections. If you can give an injection, you can give the first dose of an injection. And then you refer to a facility to continue. And that facility should be able to offer supportive therapy, because in pneumonia treatment, supportive therapy is very important. So what does WHO say is a medication to give for pneumonia? Oral amoxicillin. Certain places have a very high prevalence of oral amoxicillin resistance, so then amoxiclav or amoxicillin clavulanate. So it's not every pneumonia you need to admit. Sometimes you can manage on outpatients, like we did for our child, the 9-year-old that we saw at the beginning. So you can manage them at home. Or sometimes it's actually not pneumonia. Or sometimes it is pneumonia, but the child is recovering. This child has already taken a 5-day course of amoxiclav before coming to you. The child is running around the consulting room. You say, give me 5. The child gives you 5. The child is answering all your questions, telling stories, but you auscultate crepitations. Because the child has had antibiotics and is well, you don't need to give antibiotics. You can withhold the antibiotics. Or you auscultate their crepitations, but this child is running up and down. There isn't a problem. The mother said the child was sick a week ago, but she couldn't come. Now the cough is almost gone, but like a good mother, she still wants you to check out the child. You can withhold antibiotics, but you educate the parents to monitor closely and to come back if the child worsens. Sometimes we feel that if we don't give anything, the parents think that we are bad doctors. I want to assure you that I, a lot of times, don't give anything. And so far, if people are saying I'm a bad doctor, I haven't heard it yet. But my parents are very happy with me. And my patients are very happy with me and their parents. So you can withhold antibiotics. It depends on the counseling that you give the parents. And as part of your counseling, you need to talk to them about antibiotic stewardship. We used to treat malaria with chloroquine. Those times, even before the redenomination of the CD, those times it was pestilence. Now, when you have malaria, you're spending on Coartem more than 100 cedis as an adult, just for Coartem, because we did not protect that medicine. And where we are heading now, we see many organisms that antibiotic sensitivity, there is nothing to give them. You see, antibiotic stewardship. So you can withhold antibiotics, provided the child is well or is getting better from the story you've been told. Just tell them why you are withholding it, what they should watch out for, and when they should come. Whether you are giving antibiotics or not, you need to give them supportive care. Supportive care is that the child should eat. The child should drink. Water makes a lot of difference in viral infections. And funnily enough, when children have a cold, because their nose is blocked, they can't smell the food. They don't want to eat because smell contributes part to our appetite. They don't want to eat. So they need to drink. They need to eat. If they have a high-grade fever, you don't want them to convulse. So you have to give them paracetamol to bring down the temperature so that they don't convulse. If they are from 4 months to say 6 years, so that they don't convulse. And sometimes viruses can really do that. The example we all know is COVID. Like you have very severe body ache, body pain, so you can also give paracetamol for that. And like I said, first line is oral amoxicillin. Alternatives are amoxicillin clavulanate, cefuroxime, or fluoroquinolones. Fluoroquinolones, we need to think about the joints of the kids. So ideally, if you can't give amoxicillin, it should be amoxicillin clavulanate. Now, children who are school age, so now they say school begins from kindergarten. So from 4 years and above, consider a macrolide. But the recommendation is consider. You don't necessarily have to give the child azithromycin in addition to your augmentin. Consider it. And if you live in the community, it's very easy because you know everybody, they know you. They know that they can always come back. Consider a macrolide. Or if they've come to you and they've taken amoxicillin already and they haven't gotten better, or augmentin already, they haven't gotten better, then you need to give them a macrolide. Now, for those you admit because they are very sick, suction. Suction. Sometimes you see a child, they are nebulizing the child. The child's nostril is so blocked. Nobody is suctioning. They just keep nebulizing. Saline, hypertonic saline, they salbutamol, they are nebulizing, but nobody is suctioning the child's nose. How can the child breathe? The child will continue to have recessions because the nose is blocked. Suction. Tell the mother, keep dropping the saline drops. Anytime you see that the mucus is thick or the child's nose is blocked, put in saline drops and suction, remove it. Like I said, everybody doesn't need a bulb syringe. Even the bulb syringe, I worry even about the hygiene. But there are these cute things in the pharmacy, baby comfy nose and so on. Very, very easy to clean. It's almost transparent. You can see the mucus that are there to buy. You can use to suction. So suctioning is very, 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 very important. Mucus must come out. It mustn't sit there. And then nutrition, the child needs to feed. If they really cannot feed or they are vomiting, you need to pass an NG tube and give them food. Temperature control, we've talked about it. Hydration, water, we've talked about it. Respiratory support. It's not always oxygen. Sometimes you just need to prop up the child. Okay, so they sit in a way that aligns their airway and gives it a better chance of being open. So prop them up in bed. If oxygen is needed, you give. As soon as they don't need the oxygen, you stop. Chest physiotherapy, which we don't do. If you have physiotherapists in your facility, or if there are physiotherapists on the call, please encourage them to learn chest physiotherapy. Very, very, very important. There are simple things, percussion. Percuss your baby's chest, it loosens the mucus, and then they are able to cough it. They may not cough it out, they may swallow it. It's fine. When children swallow mucus, nothing happens. There's a lot of acid in the stomach, denatures it, and so on. There's no problem. So chest physiotherapy is important. The most basic chest physiotherapy you can do is to ask the children to mobilize or allow them to run around in the ward, jump about. That's chest physiotherapy. Okay. The fact that they are in bed, that they're sick, doesn't mean they should be confined to bed. Let them get up, let them walk around the ward. It helps to clear their airways, open it up so that we prevent atelectasis. But sometimes once the drip is on, we don't want the child to move. The child needs to move. That's chest physiotherapy for the child. If they have severe anemia, you correct it. The first choice of antibiotics, it depends on local epidemiology, immunization status of the child, clinical presentation, the immune status of the child, and so on and so forth. So WHO recommends that we give a penicillin, we give amoxicillin. But if this is a child with HIV infection, then you need to give Septrin because you are thinking of pneumococcal pneumocystis jirovecii, PJP. If this child is unimmunized, you are thinking about Haemophilus influenzae and you are thinking about strep pneumonia and so on. That's also. If this child has, there are certain diseases that I see once a while, or at least in my training, but we may not see. So I don't want to bore you, but there are certain conditions where the first line antibiotic is different. But generally, children do well with the penicillins. And then if you happen to have a blood culture or a sputum culture and it comes, then you can tailor your antibiotic accordingly. So inpatient ampicillin or penicillin with or without gentamicin. If the child has malnutrition, you must always add gentamicin, ampicillin and gentamicin, or penicillin G and gentamicin. Alternatives are ceftriaxone or cefotaxime. If you are thinking, if the history suggests staph pneumonia, and staph pneumonia, the typical history is that the child had a rash that looks like a boil, and then a few days later, then they begin to show signs and symptoms of pneumonia. Then you need something that gives cover against staphylococcus. So amoxiclav also still works, but clindamycin also. And if you are in a big place where you have culture, then you have methicillin-resistant Staph aureus, then you are going for vancomycin. We've talked about macrolide already. I've mentioned Septrin. Corticosteroids, there's a place for it, but it should be specialist level, please. If you are in a tight corner, it's much better to refer than to give corticosteroids. If you are not a specialist, that's what I mean. So if a child does not respond to treatment, okay, like our first child, that girl did not respond to treatment. What may be the problem? It may be that there are complications. Perhaps this is a pleural effusion. Perhaps this is a pneumothorax. Perhaps this is lung collapse. Okay, so it may be complications. Or it may be that the antibiotic choice was not okay. You did the first line all right, but everybody will not respond to first line. But there's a reason why it's good to start with the first line. Antibiotics still what I've talked about it. So it may be antibiotic resistance. It may be that it's an infection, but it's not bacteria. Sometimes adenoviral infection can look just like bacteria. The children have temperature 40 degrees. They are sick, very toxic, vomiting. But if you are lucky, they also have an eye discharge or they've had an eye discharge, so you can suspect. So it's not, if the child is not responding, it may not just be the antibiotic. It may be that this is viruses and it's not bacteria. It may be that the airway is blocked, which is why we should not confine the children with pneumonia to bed. Let them walk. It is chest physiotherapy. So it may be that it's bronchial obstruction. It may be that it is an infection, all right, but it may be that it is not an infection at all. So it's not bacteria, it's not viruses. Something else like oil. Those who put oil in their children's nose when they get cold, they melt the oil, they put anointing oil, cod liver oil. It may be oil or something else non-infectious aspiration. It may be that this child has pre-existing diseases like HIV that we don't know, or primary immunodeficiency that we don't know. So depending on where you are, if you get here, you may consider referral, or you may box on, depending on where you are and your level of expertise. Once this child does not respond to treatment, you definitely need a chest x-ray, okay? You need a chest x-ray. Sometimes you even need multiple. The child doesn't respond, you do an x-ray. You do something different. After a few days, you do the x-ray to see what's happening. Or when I was talking about the previous slide, TB, also consider TB. You started antibiotics, the child is not responding. Could it be TB? Because like I mentioned, in infancy, TB presents as TB pneumonia. Okay, not this you are coughing for 3 years thing. Consider a chest CT scan, but this should be at least you've referred to a specialist level, so that because we don't have money, you don't want to give unnecessary radiation, so we rationalize it. Also consider what we call a bronchoscopy. It's basically looking in the lungs to see what is there. You can take samples when you do that. Now, this thing called recurrent pneumonia. Recurrent pneumonia means that a child has had 2 episodes of pneumonia in a year. Sometimes child has fever and difficulty in breathing, and because we are using WHO classification, we say it's a pneumonia. But I'm talking about pneumonia that is short pneumonia, right? So 2 episodes of pneumonia in a year, or 3 ever. And for each of them, you had an x-ray because the child was very sick, or you did it wasn't working, or for whatever reason you did the x-ray. And you know that the first pneumonia disappeared on the x-ray before the next pneumonia came. Because we also have slowly resolving pneumonia. A child may have pneumonia and it just seems never to go away. A differential is tuberculosis. But it may not be TB and there's slowly resolving pneumonia. The difference is that in the recurrent pneumonia, the pneumonia disappeared, went away, and then it has come again. If that happens, please, depending on your level of expertise, consider referring. You can think of an underlying disorder. There are some disorders that are rare, inherited, or not inherited, and they predispose children to pneumonia. We've already talked about. As for HIV, please test for HIV, test for TB. But for the other ones, if HIV is negative, it's not TB, consider referring. Okay. If you don't refer, apart from the fact that the child can die, they can destroy their lungs, which is probably even, I don't know whether it's better to die because we are in Ghana. Elsewhere, it may not be such a big deal. But in Ghana, we don't do lung transplants. We won't give you a new lung. So if you destroy your lung, it's a very miserable way to live. So please consider referral of this child, because there are some disorders of the cilia, the hair in our airways. Children don't have it. Or anatomy. There are some children that instead of the airway being open, is so closed, those sort of things. And because it's closed, mucus can't come out. So mucus sits in there and then they keep getting a pneumonia. So what are the complications of pneumonia? Could be pleural effusion. Sometimes people get pneumonia and they create a hole between the lung and the pleura. The lung is covered by pleura. So they create a hole between the lung and the pleura. We call that pulmonary fistula, something called necrotizing pneumonia. You can also get a pneumothorax, which I didn't put on the slide. Differential diagnosis means what else should you think about, especially if you are not so sure it's a pneumonia. All the upper and lower respiratory tract infections can present like a pneumonia. Common cold can present like a pneumonia. Croup, pertussis, tuberculosis, they all present like a pneumonia. And then there are some non-infectious causes. Asthma. The child always comes with pneumonia and needs to be nebulized. Always coming with pneumonia needs to be nebulized. As for this child, when the child gets a cold, pneumonia, nebulization, think about asthma. Sometimes it's a foreign body that is sitting there. The child was playing and with a bead and was trying to swallow it. It ends up in the airway. It can be there for years. And it's there causing problem. Reflux, gastroesophageal reflux disease. Some people have some congenital malformations of their thorax. Either the lung tissue hasn't formed well or the rib cage problems. They can get pneumonia. They look like a pneumonia, may not be pneumonia, or they keep getting pneumonia. There are people who bleed into their lungs. It's not pneumonia, but if you do a chest x-ray, if you don't look carefully, it looks just like a pneumonia because blood in the lung looks white and consolidation, which is pneumonia, also looks white. But the clue is that anytime this child comes with pneumonia, this child's HB is 4 and needs a transfusion. If you think about it, then you can refer. But if you don't think, then you can't refer. Then one day they will come, either they bled so much that the lung is full of blood, it can't work, they die, or the HB is so low that they just die. There's pulmonary hypertension. There are all sorts of things. Cardiac, it may be congenital heart disease. It may be some disorders of the blood vessels in the chest, the big ones, the aorta. It may be a pulmonary embolism. So all these are differential diagnoses. The point is just think through carefully, okay? Like I said, you don't need any testing. But more importantly, if this child keeps coming with the same thing, then the question is it really pneumonia or something else that you are missing? And then you definitely need to investigate such a child. So this slide, the bottom is years from 1991 to 2023. The yellow line is neonatal mortality rate, newborn dying. So you see that line, it has come down a little over the years, even though it's not very impressive. The purple one is under 5 mortality over the years. It started from close to 100 in Ghana, but it's been coming down. Well, this is global, so Ghana, we're up there, but this is global. It's been coming down. Now we have come down. So it's not all doom and gloom. We've made a lot of advances. Mortality rates from pneumonia are very high. It's still the commonest cause, but it has come down, or they have come down. Why have they come down? The game changes. So these are the things we should focus on if we want to prevent pneumonia. Number one, exclusive breastfeeding. If you work with children, you can never stop talking about exclusive breastfeeding. You can't, because it helps. It really helps protect from infection. They are of adequate weight. They don't have allergies. It reduces risk of asthma, all these sort of things. Vaccination or immunization. When the children come to us, let's look at their child health record, the weighing book. Prevention of mother-to-child transmission of HIV, also very, very helpful. Now, people's parents can get HIV and the child will not get HIV. Treatment for HIV, highly active antiretroviral therapy, has really, really helped. Prophylaxis against PJP, Septrin, very helpful. Vitamin A supplementation, very helpful as well. So if we want to prevent pneumonia, these are the things we'll focus on. The easiest to do, or possibly the most difficult, exclusive breastfeeding. We should do exclusive breastfeeding. We should talk to our parents about exclusive breastfeeding. If you teach nursing school or you have house officers, PAs, please, exclusive breastfeeding. Always take a feeding history, baby. And then if you ask, it's when they want to tell you the problems, and then you can intervene. Probably it's attachment, it's latch, and so on and so forth. Exclusive breastfeeding. 99% of women can do exclusive breastfeeding. What is needed and what we don't provide is support. So despite all the successes we have made, there are some emerging threats. The first, I've talked about it, antibiotic resistance. Our antibiotics are losing value. They are losing power. They can't work because we dispense them like lozenges, as one of my teachers used to say. Antibiotic resistance, big problem. Please, let's be rational with antibiotics. The fact that the child's temperature is 40 degrees doesn't mean we should start with ceftriaxone. Like I said, it could be viruses. You start with the penicillin. If the child doesn't respond in 48 hours and you are upscaling, then that's justified. But don't start with 40 because Kefchazon because the temperature is 40. Or worse, meronym. Temperature is 40, meronym. No, it doesn't help us. It's putting everybody at risk. Yourself is most at risk because you are the one exposed to the resistant organisms because you work in hospital. And when so please, let's not antibiotic resistance. Then global warming and climate change, a very big threat. We have diseases now that we've never heard of before. Our weather is changing, we can't predict. Environments are polluted. Air quality, our air is too bad for us to breathe, but we have nowhere else to go. We are only on earth, so we breathe it. And pollution puts the lungs at risk of anything, most importantly, pneumonia. Vaping, now our SHS students, if you have an adolescent in your consulting room, ask for vaping. They are vaping because they think it is less harmful than tobacco, but it is probably more harmful than tobacco because the vape contains tobacco. Some of them contain as many as 50 different flavors. And some of those flavors, maybe when you eat it, is okay. But the moment you heat it into vapor, it becomes toxic to the lungs. It destroys all the hairs in the airway. It destroys the mucous lining of the airway. Vaping is a terrible thing. It is not safer than tobacco at all. And then every now and then we have these pandemics we don't know what to do about. So these are emerging threats. We should vaping, we can begin talking about it now so that it doesn't become a bigger problem already before we begin to do something about it. And as a society, we should look at it because who are being targeted by the business people? It is the young ones who are getting targeted. And if you look at the data, it shows clearly it's the young ones who are getting targeted. It's cute, it's nice, it looks cool, but no. So to conclude, diagnosis of pneumonia in children can be challenging, but it doesn't need to be. The reference is still the chest x-ray, but like I said, you don't always need a chest x-ray. Outside the neonatal period, viruses are the most common etiology. So when you are choosing the antibiotic, remember, this could be a virus. You don't want to hit a virus with meronym. It's not necessary. You don't want to hit a virus with ceftriaxone. It is not necessary. So if you are giving antibiotics, start with the lowest. But if you need to upscale, it makes perfect sense. Diagnostic testing should be reserved for situations where it will affect management or those at higher risk. For instance, if you think the child has pneumonia, you do an x-ray and the x-ray is negative. Because you think the child has pneumonia, you are going to still treat anyway. If you think the child has pneumonia and you do an x-ray and it is positive, you are still going to treat anyway. So it doesn't affect management. So you don't need an x-ray in that situation. But if you think the child has a pleural effusion, you need to decide whether it's large enough to pass a chest tube or to refer or not. And there it makes a difference in management. So reserve it for situations where it will affect management or children who are at higher risk. So it's interesting. I'm just remembering sickle cell disease when I was talking about disorders of immunity, sickle cell disease. So maybe this child has sickle cell disease. That child is at higher risk of being more severely sick or of dying from pneumonia, and so that's one. Treatment with bacterial pneumonia should begin with beta-lactam antibiotics or just plain penicillins, please. So thank you very, very much for listening. That is the end of my talk, and I hope we have time for questions. Hello. 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 I can't hear anyone, so now I'm wondering. Okay, all right.
Oh, hello. Hi, Dr. Wadri. Thank you so much. I think we're having challenges rejoin unmuting. We are very grateful to you for the session that we had with you. We had issues unmuting. Please, there are some questions in the chat, and so I'm sure, just as you said, we would have time to address them. And the first one is asking if asthma is a type of pneumonia. Dr. Wadi, please, should I go through all the questions or do them one at a time?
I may forget. So, no, asthma is not a type of pneumonia, although if you have asthma and then you have a pneumonia, your pneumonia can precipitate an asthma attack.
Okay, thank you very much. And the next question says, what's the clinical difference between bronchiolitis and pneumonia?
The clinical difference between bronchiolitis and pneumonia,
Yes, please.
you find it on examination. It's a bit nuanced. In bronchiolitis, they have a lot more air trapping. They keep a lot more air in their lungs than they do in pneumonia. And so, if you know or you are interested in percussing, when you percuss in bronchiolitis, they lose. When we are percussing, when you come to percuss, where the heart is dull because the heart is there normally. But when children have bronchiolitis, they lose that cardiac dullness. That place also sounds resonant. So it almost looks like an asthma picture, but you know this child hasn't got asthma, probably because this is the first time they are presenting like that and the age fits it. But if you are worried, you are better off treating as a pneumonia. That is if you are worried. However, if the child has a lot of wheezing, has air trapping, and is not so sick, you can just offer supportive therapy because in bronchiolitis, it's all supportive therapy. And then that's what you do. But the clinical difference is the air trapping that they have in bronchiolitis, which in pneumonia they don't have.
Thank you very much. The next question says, please, how is induced sputum done?
Induced sputum is very, very easy. It's very easy to teach your physiotherapist if you have one to help you. Where chest physio is really done, they do it routinely. When they are doing the physio, then the sputum is induced and they can give it to you to take to the lab. But if you are doing it yourself, you do. So what you do is that you use massages or chest movement techniques to make the child cough. Sometimes, if the child has a lot of mucus, just asking them to lie in it's called a semi-fowler position, so 45 degrees. They are not straight up, they are not sitting. So they lie 45 and then they take deep breaths in and out. That alone can make them cough. But you can also percuss, you percuss the chest. That can make them cough. But often where it's very critical or important, what you do is that you nebulize with hypertonic saline first. The problem with hypertonic saline nebulization is that some children get very they go into bronchospasm when you give them hypertonic saline. So you can nebulize with salbutamol first. So you find people they give salbutamol nebulization because of the bronchospasm that they want to prevent from the hypertonic saline. So first they give salbutamol nebulization, then they give hypertonic saline nebulization, then they do some chest exercises or maneuvers, and then that makes the child cough and then you can send off your sputum. There are also children who will not, they cough, but they won't bring it out. So you'll be ready to with an equipment. So to do it, a protect, you can fit your feeding tube to a syringe. And then as they cough, you have to do it a few times and you get used to it. As they cough, you suction it and you put in the bottle for your sample. That's how it's done, basically.
Thank you very much. And the next one says, please, is TB likely to occur in neonates? If yes, which investigations are appropriate?
Sorry, what's the beginning? I lost the first part.
The question is whether TB is likely to occur in neonates.
Please, can
And
you
if
repeat
yes,
the question?
is TB likely to occur in neonates? Please, did you get it?
No.
Please, is tuberculosis likely to occur in neonates? If
Yes,
yes, what
definitely. Yeah.
what
Let
investigation
me,
appropriate?
yeah. Neonates are more at risk of tuberculosis than older children, just because they are more, they have a less well developed immunity. So it definitely can occur. And like I mentioned, it presents just like a pneumonia. So you need to think about it, especially if the child is very sick or is not responding to treatment. The investigations would be an ESR, a chest X-ray, sputum or stool or gastric lavage for gene aspects. Those would be the investigations. And an HIV test. Anybody who has TB, you have to check whether they have HIV or not.
Okay. And the next question says, is azithromycin and amoxicillin combination good in treating pneumonia?
Yes, in the right circumstance. So you don't need to do it in units, because the reason why we are giving the azithromycin, the atypical organisms, neonates don't get it. Toddlers also don't get it unless it is pertussis, whooping cough. But school age children may get it. So the word is may. So you don't necessarily need to give it to everyone. But depending on the clinical presentation, if that's what you are thinking, you can. So school age children, you may, if you are concerned about it.
Okay. The next question says, please, with children with pneumonia who are oxygen dependent, is there an alternative way to manage them?
Yes. So the first thing is to say that some children, when they get sick, they really, really get sick. Maybe that child is just very, very sick. So you can allow them time to recover. And once they recover, they will need the oxygen. But you should also worry about whether there are complications that you are missing. For instance, if this child has a pleural effusion you haven't drained, they will probably continue to be oxygen dependent. So think about complications that you have not, you have missed. Also think about underlying disorders, immunity, HIV, and so on. But if all these are not true and they are really, really stuck on oxygen, please, you can refer to a specialist, or if it's a specialist, you can call me and let's discuss how to manage the child.
Okay. Thank you very much. I see a hand.
Yeah, thank you. The evaluation form for the in my network is it okay? Yeah, kindly find the evaluation form for the program in the chat box. Please make time to fill it.
I
Because
think
once
my
I
connection has started breaking, so I cannot hear.
But please, there's an evaluation form that has been posted in the chat. So we've been asked to fill the form. Our very last question just showed up. The question is, how do we get your number, Dr. Wardy, if we want to call you?
Okay, so I saw
yeah, the
that one and I
number
put it in the chat.
has been posted in the chat box.
Okay. Thank you. Please, are there any more questions on the floor for Dr. Awodri? Thank you very much once again, Dr. Awodri. We'll hand over to Dr.
Mama, Mama,
Hello, please mute your
Hello.
mics.
Let me mute my mic. All right. Dr. Daniel, please, are there any other announcements?
Not from me. Thank you.
All right. Thank you very much.
Dr. Saba, any announcement?
Yes, please. Thank you, Jonathan. So this just remind all of us that our annual dues is still, we still have a lot of people who have not paid dues. For full members is 240 Ghana cedis, and for associate members it is 120 Ghana cedis. Don't forget to send it in. The year is about to end. I do take it in installments if you want to pay in installment as well. We can make special arrangements for you so you can pay in installments. Thank you. Jonathan, over.
Right. Thank you too.
Okay. So we'd like to say thank you, first of all, to Dr. Awodri for making time to have this conversation on managing pneumonia, getting it right with all of us. I'm sure we've learned so much, and all the children we encounter in our various facilities are going to feel the impact of the lessons we've picked up from this. We'd also like to thank everyone who was present, right from the leadership of PSG to the very last person who joined the Zoom call, for being around and participating. The event wouldn't have been successful without all the questions you put out there to help make the discussion more fruitful. Thank you so much. And we know that for those who haven't paid their dues yet, we'll be hearing from them soon so that Dr. Saba would give us good feedback in our very next meeting. So till we meet again, would like to leave you with a reminder that pneumonia needs no clinic, no. Can you hear me? Hello, please, can I be heard?
Yes, please, Dr.
Oh,
Yanka.
okay. Yeah.
Go ahead, please. We can hear you.
So the reminder is that you just need your clinical findings on your initial assessment of patients with pneumonia. And whenever we are in doubt, let's make sure we reach out to whoever we can reach out to help manage our cases. Let's make sure that we take good histories and encourage breastfeeding for all our patients. Thank you very much and have a blessed day. Let's meet same time again next month for our very next session. Jonathan, please, can you close us in prayer?
Yes, please. So before the closing prayer, someone is asking how he or she can join the association. So this is Pediatric Society of Ghana Volta branch. And then if you want to join the association, we have we would share the contacts of the executives as well. You can contact me as well so that I would explain to you, and then how you'll be able to join, we'll explain that to you as well. So you are all welcome. Let's take the closing prayer. Father Lord, we thank you for making this meeting a success. Father, thank you for the facilitation. Thank you for giving us enough knowledge to take care of our young ones. We pray that we don't do away with the knowledge we've learned, but we practice and learn more on it and give back to the society. This and many more we ask through your Son Jesus Christ. We pray with thanksgiving. Amen.
Amen.
Please, how long will it take to receive the certificates?
Let's just say soon. I'm not sure it will reach 2 weeks. Within next week, you will receive it.
Thank you.
So to be specific, I need to verify those who have made payment. So I need to compare it with the Zoom, those who did the Zoom registration and then the Momo number as well. So once that is done, so let's give ourselves in a week, we should be able to receive. You will receive an email with your with the certificate in it.
Okay, thank you.
Okay.
Okay. Have a nice day, everyone.
Okay, thank you.
Bye.
Thank you for joining.
Thank you too.
Dr. Audrey, thank you so much.